Hello, everyone, and thank you for joining us for today's webinar, Healthcare Transformation, How Pharmacy Can Be a Lever for Mission-Centric Change. Before we begin, I'll walk us through a few quick housekeeping instructions. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and it will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you have issues with audios or visuals, please try refreshing your browser. You can also submit any technical questions into the Q&A box, and we are here to help. With that, I am pleased to turn the floor over to today's moderator, Allison Arant, to jump into today's discussion. Over to you, Allison.
Thanks so much. Good morning and welcome. Thank you all for joining today's webinar. We are eager and honored to have all of you here, and I'm honored to moderate this conversation with three folks who you'll meet here in just a second. The topic of today's webinar is Healthcare Transformation, How Pharmacy Can Be a Lever for Mission-Centric Change. And I am pleased to represent Clearway Health today. Clearway Health transforms specialty pharmacy for hospitals and health systems across the country. And with us today, we have the Brooklyn Hospital Center in Brooklyn, New York, who is one of our client partners that we have worked to build and strengthen their specialty program. On today's panel, we have several guests. One is Dr. Aman Kahasi. Aman is with Clearway Health, and he leads our clinical pharmacy and drug information team, partnering with clients across our client organization. And from the Brooklyn Hospital Center, we have Dr. Bob DiGregorio, the Chief Pharmacotherapy Officer at the Brooklyn Hospital Center, and Dr. Lenny Berkowitz, who is Chief in Division of Infectious Diseases. So thank you all for your time. Thank you for the expertise and the stories and experience that you'll share today. And with that, we're going to jump in. So we'll start by laying a foundation of what is specialty pharmacy. And so we're going to start, Bob, with you to really talk about what specialty pharmacy is and how it benefits not just patients, but also hospital health system organizations. So tell us a little bit about specialty pharmacy and especially what that landscape looks like at the Brooklyn Hospital Center.
Sure. Good afternoon or good morning, everyone, depending where you're logging in from. We started on this specialty pharmacy pathway, I'd say, back in 2017 when we opened our first retail pharmacy within the hospital. And we knew back then that having a retail pharmacy would perhaps bring in revenue to the hospital. But we knew that there were a couple of pieces that needed to be in place for that to really work out for the hospital in a favorable way. And one of them was to be a 340B eligible institution, and the other was to have a specialty pharmacy designation. And that term specialty pharmacy, I think, is tossed around a lot and can be kind of nebulous. Specialty pharmacy really is an accreditation. It's not really a separate pharmacy per se. Our outpatient retail pharmacy is our specialty pharmacy. What makes it a specialty pharmacy is that we've undergone the accreditation to be recognized and give us access to limited distribution drugs. So having that ability really has opened up a revenue stream for biologics, some antivirals, medications that normally one either wouldn't have access to because of restrictions from either the insurance company, PBM, or directly from the manufacturer, or they may be just medications that require extra special handling, additional patient monitoring, typically high cost, really high touch services and medications. And I think, in general, if you're wondering what a specialty drug is, you need not go any further than put on your TV and, watch the commercials between your favorite shows. It used to be that you'd see cholesterol drugs and blood pressure medications being advertised, but the direct-to-consumer marketing now is essentially all of these biologics for rheumatoid arthritis or GI disorders. All of those drugs are specialty drugs. And to get access to those drugs as a patient, there are hurdles to get through with prior authorizations and special levels of education and monitoring that are required. So that's what specialty pharmacy is. It does require you to have a retail pharmacy in place to be a specialty pharmacy. So it's not so much that it's different, but maybe perhaps a extra layer or a enhancement on your retail pharmacy.
That's great. Thank you for walking us through that. Aman, I want to come to you next because Bob's really laid the foundation of how it's been important and how they started this journey and navigating it at the Brooklyn Hospital Center. In your role, you see that view in a much broader way across the industry and think about things like drug pipeline and the direction that specialty pharmacy is going to help enable and equip to be successful. Talk a little bit about that landscape from your perspective.
Yeah, absolutely. And hello, everyone. My name is Emmanuel from Clearway Health. I think what I wanted to add to what Bob mentioned is to highlight some of the key points, maybe perhaps two, in the genesis of specialty pharmacy in relation to the overall health system care delivery model that we've been observing on the last decade or two. To begin with, over the last decade, we've seen a concerted effort by health system to minimize or reduce hospital admission and keep patients out of the inpatient services at the same time while developing or expanding their ambulatory or outpatient care model footprints. In parallel to that, what has happened was there was a significant improvement or innovation in terms of new drug approvals, mainly the biologic therapeutics or small molecule targeted therapies. For example, if you take a look at the FDA approval pipeline, you would see more than 50% of the newly drug approval fall under the specialty pharmacy or specialty drug category. Although these specialty drugs account for about 2% of the total prescription volume, they are expected to account for roughly 45 to 50% of the total drug expense in the healthcare system. So one can appreciate the opportunity this new therapeutic drug development brings clinically, and also the financial burden that it brings also to the healthcare system. So taking all these things into consideration, the shift that we've been observing towards the ambulatory care or outpatient care model helps health systems to deliver quality healthcare in a cost-effective fashion. At the same time, it also allows them to tap into the 340B saving opportunities that otherwise could not be realized through the inpatient care services. But again, like like Bob mentioned earlier, most of these medications are highly complex, specialized therapeutic options that require a certain level of expertise in terms of handling, distributing, or patient monitoring. And oftentimes, they can only be accessed through a specialty pharmacy with appropriate accreditation to showcase their clinical and operational service excellence. And it's now intuitive for health system specialty pharmacies to develop their specialty pharmacy so that they can gain access to these life-saving therapeutic options so that they can deliver optimal care to their patient at the same time while actually realizing the revenue that comes with it as well.
Mm-hmm. Thank you for that, Aman. Dr. Becker, we'll come to you next and really representing the medical perspective. You're sitting in clinic and taking care of patients who you are prescribing specialty prescriptions for. So talk to us a little bit about the landscape of specialty pharmacy from a medical provider and how you and your patients are navigating it.
Okay, thank you. I'm the supervisor of our comprehensive HIV center, in which we treat 1,200 people with HIV, and have treated about 150 of them for hepatitis C as well. These are all the drugs involved are specialty drugs, but the key thing for our patients is staying on their medicine, making sure they always have access to their medicine, don't have any breaks in their treatment. This is especially important now with the new injectable treatments for HIV. We have about 140 patients on injectable treatment for HIV and another 50 or so on the injectables for PrEP. It's crucial for us to be able to get these drugs in a prompt, reliable way and to have them ready for the patients on the dates that they're expected to be here. And partnering with the specialty pharmacy group right at our hospital has allowed us to have really tight control over all the distribution of the medication. We know in advance if there's going to be any problems, such as an insurance issue. A major problem has always been getting prior authorizations, which are not only difficult sometimes, they're a real time waster for our staff, for the physicians, PAs, anybody who's got to do a PA. I don't know how many physicians are out there, but if you've ever had to do a prior auth, you know what a nuisance it is and how much time it takes. So the specialty pharmacy staff has done all the prior authorizations for us, which relieves us of that possibility. They know in advance when patients are due for their medication, and they let us know if anybody needs a refill. They deliver the medications, and the injectables especially are sent to us prior to the day the patient is coming in for their shots. So there's been remarkable improvement in consistency. Treating HIV is very easy now. Prescribing is very easy, but it's all about getting patients to take their medicine properly. And in our population, we have a large number of patients with substance abuse histories, mental health issues, other chaos in their lives that makes it harder for them to keep track of their medicines. And this has been a terrific advance for us in being able to keep everybody on their medicines and keep them well controlled.
Thank you for walking through that. I think it helps to set the stage to really understand that connection point between the genesis of a retail pharmacy, the evolution of providing specialty pharmacy services, and then the way that connects and impacts you as a provider, and altogether all of you as an integrated care team. The next question will really walk us through understanding a little bit more about how you're designing clinical programs that are led by the specialty pharmacy program and team. And so this panel represents this collaborative approach to these programs. But Aman, I want to start with you to really walk us through how we start to look at the clinical programs in the way that we ensure the success and the adherence and the participation that Dr. Berkowitz just talked about.
Yeah, absolutely. So I think at Clearway, our specialty pharmacy service have both the clinic embedded pharmacy team mainly focusing on the clinical service piece of the puzzle. And then we also have a specialty pharmacy team that focuses on the operational excellence piece of the service. So our clinical pharmacists practice under collaborative practice agreement that allows them to prescribe new medications and modify therapies and put lab orders and interpret and actually make appropriate interventions based on the results. And on top of the routine medication access service that we provide, mainly the prior authorization and financial support access, we also take on the peer-to-peer discussion and appeal process should a prior authorization is denied. Dr. Burke was mentioned the challenge of prior authorization and fighting off back by providers due to lack of bandwidth. So this guarantees two things. One, a timely and affordable care to our patients. It also opens up the bandwidth for the providers so that they can see more patients within a given time period. However, I do recognize some health systems or maybe some leaders will probably see this model as additional cost of care, especially in a setting where most of the specialty or the clinical pharmacy services are not billable services to generate its own revenue stream. But at Clearway, we assess our return on investment or our value assessment with additional key data points. For example, the American Medical Association published an article in 2021 showing more than 80% of the providers who responded to that survey would abandon their preferred therapeutic options because of the challenge of the prior authorization they face. And bandwidth or maybe the lack thereof of the providers is key here. Providers do not necessarily have all the time to stay on the phone with the insurance to fight off prior authorization denials. So we take that administrative burden from the providers so we can guarantee, one, we can reverse the denials on time, get medication access to our patients. So that will result in an increased volume of prescription from a given clinic to come out in a certain period of time. it also creates a clinical excellence that could be translated into revenue stream to justify the ROI. Another thing that I wanted to highlight is most of these specialty medications would require some level of monitoring, especially in the first few months of therapy starts. And if you have a rheumatologist, what is the likelihood that the rheumatologist will be able to see the patients within 6 to 8 weeks after initial therapy start to assess for adherence and side effect profiles? And then after 3 to 6 months until they achieve the clinical or therapeutic goal. So our model actually fills this gap in care so that we can offer a consistent and timely monitoring to patients with the opportunity to make clinical intervention and make sure that patients are actually adherent to therapy, persistent to therapy, and have a good clinical outcome by the time they come to see their providers. And the other piece that we also look at is across many therapeutic areas, there is a significant gap in terms of early diagnosis to certain disease states and linkage to care. Our care model, as it's exemplified with our test to treat model, primarily led by a pharmacist in HIV and Hep C treatment, we are able to monitor through a technology-supported dashboard the complete patient journey from initial diagnosis lab result to linkage to care to achieving the viral load suppression, making sure that patients are getting the access and the clinical or therapeutic outcome is realized. This also have service excellence value to it that can lead into accreditation, payer access, and revenue generated to the health system as well. And if you are practicing in a healthcare that practices under ACO or maybe value-based care, there is also a value in terms of cost saving or cost avoidance perspective. For example, we know a lot of patients will flare and hit the emergency department or maybe admitted to the inpatient. Or maybe you have a patient population that has high healthcare cost utilizers. So by designing a clinical program to proactively address the challenge that these patients face that's leading them to have high healthcare utilization and making sure that they maintain their health while reducing the cost of therapy will have another value that we can generate through our care model.
Aman, thanks for walking through that. Dr. Burgess, you talked earlier about really the concept of adherence, and you talked about the benefit of a program like this providing connections to care. Will you share a little bit about who's included in that process and how it has impacted positively the added folks that are a part of your care team, the impact it has on your staff, and then really how it's created a successful integrated approach to specialty pharmacy?
Sure, it's taken a great deal of work away from our nursing staff and clerical staff to keep track of a lot of these things. And it's being done in a way where they're part of the pharmacy team, besides doing the PAs, which we're eternally grateful for, but they keep track of who needs what drugs and when they need them. So our nursing staff doesn't have to do that anymore. And they make sure that all the prescriptions are in order, and they make sure that they bring the drugs to us directly. Since this program has started, we've actually not had a single person miss an injectable dose. We have 140 plus 50, 190 people on injectables. There have been 0 missed doses in well over a year now. And of those patients who are on the injectables for HIV, 100% of them have maintained viral suppression, which is the bottom line for us. That's how we know that everything is working well. We still have, many of our patients get their oral HIV drugs from the specialty pharmacy as well. Every one of them has had their drugs delivered on time. We still have a significant number of patients getting their oral medications outside pharmacies that they've gone to for years. And there are still periodically, they'll come into their visit and say, I've been out of meds for a week because my pharmacy had it on back order, or my pharmacy couldn't deliver, so I missed 10 days of drugs. These happen in real life all the time. So what's been really helpful is the consistency that we've seen since participating with the specialty pharmacy that's co-located with us right in the hospital.
I think that deserves a congratulations. That's a tremendous accolade to say that 100% viral suppression, 100% on-time med delivery, and that just takes incredible collaboration between so many different team members. So appreciate you sharing that story. Bob, we talk about what it takes to make this successful, and we get to sit on a panel and talk about the success stories, but we often talk about the importance of having pharmacy leaders at the C-suite and at the executive table really leading some of these strategies, but knowing that it is so cross-collaborative outside of just the pharmacy and the medical teams. Will you talk a little bit about the impact on collaboration at the executive level and really who those stakeholders are to make this program successful?
Sure. So, it's easy to say from the patient perspective to have a successful program. The patient would just come in, see Dr. Berkowitz, he'd wave his magic wand over them and they'd be cured. But all of the work behind the scenes, they don't know about, right? I think that we go back 20-something years together, Dr. Berkowitz and myself, working, at the hospital, building a pharmacy structure for his clinic so that we were able to embed clinical pharmacists in his interdisciplinary team. And I think that really laid the groundwork for being able to advance the model into the specialty model now. So I think, one of the steps is recognizing that you need a strong pharmacy team before you maybe introduce the specialty layer in. Otherwise, I think that there'd be some growing pains there. So in addition to having, the strong physician and clinic team, having a pharmacist embedded in the team that is already educating patients, already using maybe a collaborative drug therapy model, so the patients are educated about their medications is really important. And of course, that requires, justification at the executive level to add a pharmacist in. Now imagine you want to convince your executive team to add additional liaisons onto that team and to now start stocking medications in your pharmacy that are very high cost medications, and to have a courier service to make sure that they're getting delivered. So you can start to reap all the benefits that Dr. Berkowitz alluded to get that 100% viral suppression. So, there are a lot of people working behind the scenes to do those prior authorizations, to procure the medications and store them and make sure the bills are paid, and have all the data to support all of that justification. So there's a lot of unsung heroes, in the background. Everyone from your technology people, your information technology people, finance, your operations people, as well as your pharmacy and your medical and nursing, and the usual players. So there's a lot of overlap, a lot of relationship building, and a lot of justification to make that leap into what is kind of a very costly investment, but with a very good return on that investment.
Yeah, that's great. That's great. I think, every time I hear you all talk about the program, and it's really thinking about who the beneficiaries are, and you represent so well the fact that the providers and the clinicians and the care teams are so much your client in the way that you approach that for all the things behind the scenes that you make easy to work through the process. So appreciate the perspectives that each of you shared. We've talked a lot about the construct of specialty pharmacy. We've talked about team members and high-level impact. There's always data behind this that really drives where we target and where we choose to build these clinical programs. Certainly, all specialties have the ability to serve patients with a higher touch model through these specialty pharmacy services. But I want to come back and start, Bob, with you to really talk about this next question, which is what kind of data and analysis is needed to drive these clinical programs that specialty pharmacy is leading? So we'd love to hear you pick up and talk a little bit about the analysis and how you go through navigating that at the Brooklyn Hospital Center.
Sure. So, I alluded to one of the people behind the scenes is your information technology people, and really having a pharmacy informatics person who can pull data from your EMR, who can look at SureScripts data and really figure out where prescriptions are going. It was actually quite eye-opening as we started building out our retail pharmacy, and then even more eye-opening as we got into the specialty realm to see actually what our prescribers were writing for and where those prescriptions were going. I didn't really imagine the scope of how many specialty prescriptions were being written by our providers and going outside the institution to other specialty pharmacies. So having someone that is familiar with speccing out reports and being able to pull that prescribing data from the EMR is really valuable. And without that, I think you don't have a leg to stand on to justify building out a program like this.
Good. Thank you.
Sure.
Go on.
Right.
I was just going to add about the endocrine and rheumatology marketplace. Those were areas that, in particular, were high volume prescriptions that we didn't realize. The Hep C and the HIV, because we were already embedded in Dr. Berkowitz's clinic, we had, a good feel for those. But some of those other areas where we did not have a pharmacist embedded in the service already, those areas were quite eye-opening without having that the data previously.
That's great. Thank you for walking through that. I think the data is there, and harnessing it is certainly a common challenge. Dr. Berkowitz, would like to hear your perspective from the provider angle and how some of that data analysis is critical for the clinical initiatives and requirements. There are certainly things that you are focused on as an organization at TVHC, things that the state of New York require. Would like to hear really how the collaboration between pharmacy and the medical team has helped to deliver on some of those initiatives.
The major disease state in which we've had success with that is the hepatitis C program. Before we had this integrated program, we would have a report from the lab whenever someone had a positive hepatitis C antibody test, but then there was no process for acting upon it and making sure those patients were followed up. With the process we have now with the specialty pharmacy, first of all, they were able to change we work with the EPIC people to do our EMRs to change the way that hepatitis C testing is done, which should be done nationwide. There's a CDC mandate. Everybody 18 years and older should be hepatitis C tested at least once. The mandate is to test everybody, and then you should have an antibody test that reflexes automatically to hepatitis C viral load to see who needs treatment, and that's done now automatically. Honestly, we tried to get that done for years, and we got nowhere. But once the specialty pharmacy folks assisted us, the hospital paid more attention, and EPIC was able to change the way we do the testing, and also able to put in an automatic reminder on every patient who pops up to remember to get a test for hepatitis C. In addition to that, now when the tests come back positive, there is someone who works with the specialty pharmacy who will track down that patient, speak to us about whether they're appropriate candidates for treatment, and make sure that if they are candidates for treatment, that they come in, get treated, and get followed up to make sure they're taking their treatment, getting their drugs properly, and getting the prior authorization, which again is one of the biggest challenges in Hep C treatment because the medications are so expensive.
Hugely important. And Aman, I'll come to you to talk a little bit about really how you're curating that data and providing some of that insight to build these clinical programs. And then also talk a little bit about how we anticipate and measure success, because we are building these programs. We're hearing the outcomes from Dr. Berkowitz, especially for the Hep C and HIV patients. But talk about how you're defining success through data analytics and how we're benchmarking those types of things in our work.
Sure, absolutely. I think from the program development perspective, we do leverage public health data and the health system data to validate our concepts to begin with. For example, if I were to go to Dr. D to pitch an idea for a new clinical service development, I need to have some insight in the value of that program and what it takes. So we leverage the data that we have access to size the opportunity before we even start building the program, and validate within the internal data if that publicly available data actually is telling us the true or the full story. For example, you can take a weight management program that is probably center of discussion across the nation at this time. We know from the public health data, about 50% of patients who meet the clinical definition of obesity, meaning body mass index of 30 and above, do not actually have official diagnosis of obesity or overweight. There's a lot of reasons for that, patient-related factors, provider-related factors. But the reality is there is a significant gap in actually diagnosing them and linkage to care. And if you compare with other chronic diseases, obesity being one of the common and common risk factor to most of these hypertension, diabetes, or other cardiometabolic diseases. Linkage to care for obesity through pharmacotherapy is very, very low compared to the other disease states. So it makes sense for health systems to set some level of priority to address obesity first, so that the healthcare utilization of managing the other chronic disease that results from obesity probably will be lower going forward. So what we do is we leverage that data and see if we can develop a clinical program that can offset this clinical and financial burden. Now we know with the emergence of the GLP-1 receptor agonists, there is a significant opportunity to treat as many patients as possible, except this new therapeutic class also comes with a significant financial burden to the health system and to the payers as well. So one has to come up with a strategy to make sure that you have a financially viable program while you're actually delivering care to all patients that are eligible for care. So we do all these payer mix, margin, reimbursement, and assessment before we even come up with the program design and pitch this idea to those executive bodies to demonstrate the value of this clinical program to get a buy-in. From the outcome perspective, for every clinical program that we develop, we have success metrics in terms of clinical outcomes and financial outcomes also. For example, for HIV and Hep C, we constantly monitor their viral load level. We need to make sure that patients are achieving their viral load suppression. Dr. Burke was mentioned earlier, TBHC patients have 100% viral load suppression, which is great. Across the company, patients who are managed by healthcare, by Clearway Health, have more than 95% of this patient population under our care actually achieve viral load suppression. If you compare this one with the national average data, which is 65%, it is significantly high in terms of patient care. At the same time, we also monitor their CD4 count. CD4 count is the measure of their immune strength. So if we see patients having lower CD4 count, we can actually make an intervention so that they can prevent, or we can prevent the opportunistic infection. So we monitor all these clinical and patient-reported outcomes every time we have an encounter with a patient, and we document and demonstrate that one. And that comes really handy when it comes to provider engagement, because when you're developing a program, you have the executive level buy-in and provider buy-in as well. Like Bob mentioned, providers probably sometimes will send prescriptions at outside pharmacy. For the provider, what is most important is their patient getting the ultimate service to drive a better clinical outcome or not? So by demonstrating our clinical and patient-reported outcomes to these providers, we can also influence the prescriptive behavior, or maybe influencing providers to get a buy-in to our program so that they can send prescriptions to the internal pharmacy, so that we can actually serve these patients to achieve their clinical goal. We could do simple analysis of comparison patients under the specialty service management internally versus outside, and then we can compare the outcome data, and then the data will speak for itself when we're developing the services and getting the buy-in.
That's great. I want to take it straight to the patient. We've talked about overall program. We've talked about the data and the analysis, but Really, when we think about patient-centered care, what are the ways that these specialty pharmacy-driven clinical programs are improving care delivery and access to care for patients who need these medications? So, Bob, let's start with you to really talk about the care delivery and access to care and the way that you're able to balance that with incredibly healthy financial performance and margin.
Yeah, so, we always face this paradox in care where, we know that if patients take their medications, they'll be healthier, they'll stay out of the hospital, we'll reduce their readmissions, but patients often can't afford their medications. So, we have that one element of, how do we get medications to patients to reduce the utilization of care, allow us to see more patients means more volume means more revenue to the hospital. So, historically, we've done things like meds to beds programs, making sure patients leave with their medications. And we know that that's successful, right? That reduces readmissions. The specialty pharmacy program, having it as part of, our whole approach integrated into our clinics, into our own outpatient pharmacy, is kind of an extension of that meds to beds mentality. If we can make sure that our patients are getting the medications, then we know the outcomes are going to be better. And it allows us to extend our footprint and see more people. That is complicated in a way by the fact that these are very expensive medications and have prior authorizations and all the things that we've been talking about on this call so far. For the hospital to maybe implement more programs like a meds to beds or meds to clinic, or to embed more people in a clinic to improve adherence, all of those expenses have to come from somewhere. So, if I go to the CEO and say, oh, we want to do this great program and we're sure we're going to improve adherence rates, we're going to get more patients in to see Dr. Berkowitz or the other providers, he tells me, well, we got to keep the lights on, and how are we going to pay for the lights? Much less the salaries of all of these people that you want to hire. So, there's a kind of a catch-22 that we need to find programs that have enough of a return on the investment, that the margin is high enough that we can actually do good for our patients. And, probably the biggest program, the best program that has come our way has been the 340B program to enable us to do that, right? So by being a disproportionate share hospital and being able to get our medications at a lower cost and still have that margin in our favor, that enables me to go back to the CEO and say, well, not only can we keep the lights on, but now we can actually justify some of these additional resources that we need, and including resources like having a patient assistance program. So even with coverage for the specialty medications is often a high copay or deductible that patients may have to meet. So being able to offer a patient assistance program as a charity fund, is something that historically we wouldn't be able to do, but because we're able to, have such a good return on this investment, we can actually invest back in our patients and make sure that financial, constraints are not the reason that they're not taking their medications. So, hopefully a little bit of profit from the sale of the drugs and the fulfillment of their prescriptions, the 340B margin that helps us, and being able to kind of pay that back as is intended by the 340B program, kind of all works out, and everybody wins.
That's great. I appreciate the concept of that modernized approach to pharmacy, the modernized, movement from what was historically very inpatient-focused beds to beds, and the way that you're expanding and accelerating that in the outpatient setting, especially the nod to the 340B program and just the compliant ways that you're navigating the program and maximizing the benefit for the organization who serves underserved patient population. Dr. Berkowitz, I'll come to you to really talk about that care delivery and access to care impact in the clinic with the patients that you serve.
Okay. Well, the major improvement in care delivery is the reliability and consistency with which everybody gets their medications. The major change in access to care has been with the injectables. There's been a tremendous demand on the part of people with HIV to get these injectable treatments. They discuss them with their friends. They know how convenient they are and how effective they are. There are quite a few programs in New York which were very slow on the uptake with these because there was a lot of work involved and they didn't have the staff to do it. And there's still several programs that are similar to ours overall, but have very few patients getting injectables because of all the steps along the way to get it done. Before we had the relationship with the specialty pharmacy, we would do the PAs. It would take several days, sometimes a few weeks, or sometimes not get it at all. And now that process is down to an average of 1 to 2 days. We've actually had a couple of patients who we saw them in the morning and decided we agreed to make the switch to the injectable, put in the prescription, the PA was obtained, and the pharmacy brought us the medication before the patient's clinic visit had finished, which was quite astonishing to us. We'd never seen that before. And there are still quite a few programs where they are just they're not anxious to offer the injectables to patients because of the complexity of the delivery. So that's been our major advantage. We have patients come to us from other programs because they heard we give injectables and their programs are still not offering it to them.
Thank you. Aman, we'll come to you next. You often talk about the patient perspective in specialty pharmacy and talk about the patient education and the patient choice in navigating this process. One of the questions that came in from the attendees today is, how are you educating patients on making this choice to choose your own pharmacy? Would love just to hear you talk a little bit about the approach and ways that we've been successful in improving care delivery and access to care through partnering with Brooklyn Hospital Center.
Yeah, absolutely. Thank you for the question. So I think our model actually lends itself to early conversation with the patient. So the fact that we have a clinic embedded pharmacy team would allow the physicians to have a warm handoff of these patients for additional clinical discussion. In my previous role as a clinical pharmacist, there were moments where patients really appreciate the additional clinical discussion in terms of disease education and medication education that we can offer in addition to the providers' education. The key point here is in most health systems, providers probably have 25 or maybe 15 to 25 minutes visit time slot. It is really, really hard for physicians to address all the needs of the patient, including the disease state and medication education within that limited time period. So the fact that the pharmacists and the liaisons at the clinic take over that visit and educate the patient in terms of their disease state, the expected outcomes of the therapy, and the level of support that we can provide, regardless whether they feel with us internally or not, that sets the tone that we are actually putting patient care and patient outcome first. And when it comes to the prescription capture, it comes very natural and easy discussion with the patient because you already have assisted this patient without anticipating to fill the prescription in-house. So that trust is already built. The other piece is when any patient wanted to communicate with their care team, there's always some lag time because of the busy nature of the providers. Some providers have to wait at least 72 hours to get a response from their providers. The fact that we have a clinic team that is always available, directly available without any transfer of calls, they can directly call our pharmacy team to get the success. The assistance that they needed. It gives them more comfort. They don't have to bother Dr. Berkowitz nurses for a simple question. They can directly access our team and get the answer. If not, our pharmacists can just stop in Dr. Berkowitz's office and get the answer and deliver to the patient back without waiting some days. So all these clinical service that we provide, regardless whether we fill the prescription or not, is one thing. The second thing is we also leverage our patient-reported outcome or success stories that we have. We can show patients, if you are using our services, we can extend this level of services and your outcome will be this one. So the data that we collect and publish actually helps to gain more confidence for patients. If they are feeling internally, they'll have extra support that helps them in their disease and medication management as well.
That's great. That's great. Let's take that and jump into a similar concept, but more focused on social determinants of health, as we're really looking to help patients navigate their care pathway once who are prescribed specialty medications or perhaps have been on them for a very long time. How do these pharmacy-powered clinical programs support and positively impact SDOH? And Aman, we'll stay with you to start this one.
Yep. So I think we are at a time where pharmacy services, integrating clinical pharmacy services with population health approach makes a perfect sense, particularly for health systems that practice under the ACO or value-based care. So, for example, if you take a patient with inflammatory bowel disease in your GI clinic, there is a significantly high rate of ED admission or readmission to the hospital due to simple flare. And this is because most of these patients are on long-term steroid therapies, and the moment that they are taken off the steroid due to refill challenges or other reasons, they quickly flare and hit the ED. The other piece is we also educate patients on the long-term use of steroids is not necessarily good for their overall health. So we leverage the data from the health system and risk stratify the risk of these patients and the financial consequences of these patients who have significant social determinants of health challenges. Then we can actually create or design a clinical service to proactively identify these patients who have certain challenges and then intervene appropriately to make sure that they are staying off the ED or hospital admissions and mainly improve their clinical outcome. To Dr. Berkowit's point, he mentioned the the injectable, long-acting injectable drugs for HIV or PrEP management. Even though these medications are really, really great, especially for patients who have some socioeconomic challenges where daily oral dose to HIV medication or PrEP services is a challenge, these medications offers a different level of service that they can benefit from. But as Dr. Berkowitz mentioned, these medications require significant care coordination to make sure patients are getting the medication on time on the clinic visit, not only for the first dose, but the subsequent doses has to be aligned with their next visits as well. So we identify this patient population that have certain social determinants of health challenges. So we try to address all the needs that they have. And while staying in that HIV topic, if you take a look at the national data, the patient population that makes about 2/3 of the new HIV diagnoses are either socially or racially minority patient population. That highlights the need to address their social determinants of health, mainly the health literacy, access to healthcare, access to uninterrupted medication access, and so on and so forth. So then we know food insecurity or maybe nutrition insecurity plays a key role in HIV management. Mainly, you want to make sure that the patients have access to shelter, access to food security so that their immune system can actually withstand the disease, and the medications sometimes require to be taken with food. So taking all this into consideration and assessing in each encounter that we have with the patient what challenge that they have so that we can work with other care team to make sure that these barriers are alleviated from the patient so that they can continue with their care makes a really significant impact in the care.
Yeah. Dr. Berkowitz, you talk a lot about screening programs and the benefit and impact that they have had. Will you talk about your experience, especially in these services, perhaps through screening programs and the impact that it's had on SDOH for your patients in the community?
Well, the screening program that's been most impactful has been in the emergency department where they're doing hepatitis C and HIV testing, because there's a lot of people, we service a predominantly poor population, not well-educated population, and a lot of them don't have physicians, they don't have a primary care doctor, they go to the ER whenever they have an issue. And these patients would be lost to follow-up if we didn't have a system in place for screening. And then when those tests are done in the ER and the results come back to us and through the specialty pharmacy staff, those patients are tracked down and we try to get them into care. And without the services, that would be very challenging to actually try to get them to successfully get them into care. And as far as our HIV patients, our major population that we have, about 95% of our patients live at or below the poverty level or on some kind of public assistance. And just having the specialty pharmacy just, again, allows us to have the knowledge that they're going to have consistent and reliable access to their medications.
Thank you. Thank you for talking through that. We have just under 10 minutes and a final question. There's also been several questions that have come in through the chat. Some I think we can roll in here. Many folks are asking if we are first developing a specialty pharmacy program, what are some pitfalls to avoid or recommendations that you have? Others are asking more specifically about building types of clinical programs, but each of you would love to hear your perspective and your send-off on where should folks start when they're looking to build or strengthen their pharmacy-led clinical programs within their organization. And Bob, we'll start with you on this one.
Okay, and I'm just scrolling through the questions as you're talking as well. So I guess some random things that come to mind. In starting out, it's a bit of a heavy lift in the beginning. It's the you don't know what you don't know phenomenon. So using an accelerator like Clearly really was very helpful for us. It also was a good way of instilling confidence in our senior administration that we would be successful. I know, and I see some of my colleagues that are on the attendee list for the call are at places that have taken this on their own and have their own specialty pharmacy from day one that they've managed. And my hat's off to them because I now know all of the hurdles that they had to jump through to get up and running. It's an investment of resources and an investment of inventory, giving a level of confidence to your CEO that that investment will pay off, is a challenge. And being able to partner with an accelerator that has some track record and, can pull data and compare data to other institutions and give you that sense that, you'll be successful is very important. And, I don't mean this to be an advertisement or a plug for Clearway as much as I do like working with them. It's not, this is sincere. Their pro forma for us was really spot on. Within a decimal point of what we've been able to achieve. So having that level of data management and confidence in the data is really important when you're trying to get started out. The biggest challenge, of course, is getting accreditation. And that could be minimally 6 months to a year or more to get that specialty designation. So one of the questions I see in the chat was about why do you have to have a retail pharmacy first? I suppose you could jump right in and just be a specialty pharmacy, but you got to keep the doors open and pay people for a year, before you're going to fill a specialty prescription. I think being a retail pharmacy first and establishing your business model and then adding on is a wiser way to go. Of course, there are what we refer to as specialty light medications, and perhaps we can highlight, it was already alluded to, the weight loss medications. Those are technically not limited distribution drugs, but become specialty light or like because of the prior authorization process. Starting a program like a weight loss program can perhaps front load you with some revenue and not require accreditation to fill those prescriptions. The HIV and the Hep C drugs, while they require the prior authorizations and have financial constraints, are not really limited distribution drugs per se. So you can start out as a specialty pharmacy if that's what you're going to call your specialty medications. But really you can be filling those things while you are in retail pharmacy mode. And seeking your accreditation to be a specialty pharmacy. So I hope that addressed some of the questions lumped together there. I don't want to hog up all of the time, so I'll pass off to Dr. Berkowitz.
I think one of the key factors in starting a program like this is getting buy-in from your physicians, because they're going to be a key cog in this process. And if you just begin approaching your physicians by saying that, number one, someone else will be doing all the prior authorizations for you, you'll get their attention right away. But that is crucial, but more importantly is that it's tied into better patient outcomes. We do have 90% viral suppression throughout our clinic, but 100% in the patients who are linked to the specialty pharmacy. There are clearly better clinical outcomes associated with the process. That, along with not having to do prior authorizations, will get your physicians interested in participating in this. And they should be in from the beginning to help outlining the programs that you're going to be designing for screening processes or making changes to your EMRs. You want your physicians involved from the beginning.
I think what I wanted to add to that is if you are a health system leader, probably thinking about this opportunity, then the first thing is just to do the SWOT analysis and scan the internal capacity. I think the need for a specialty pharmacy service is not debatable at this time because of the revenue and care excellence that it delivers. It's a matter of how and when you should do it, in my opinion. So when you do this internal scan, it will also give you an insight. Do you have the capacity to actually develop and roll out and maintain these services in a timeline that you have, you wish to do that? So if that's the case, like Bob mentioned, some people will go ahead and develop that service by themselves, and sometimes they're very successful. Or if you don't have the internal capacity to execute this one in a timeline that you hope to achieve this one, I think it is intuitive to partner with specialty pharmacy accelerators like Clearway Health to provide you support. Developing the specialty pharmacy service, as Bob alluded, is quite daunting task. The URAC accreditation, ACHC accreditation, and other accreditation that are required for you to be able to fill and access the LDD medications is one piece. Payer access is another issue because it's highly related with the service excellence and outcomes. So in my opinion, I think health systems will benefit by partnering with specialty pharmacy accelerators like Clearway, since we've done this one over and over in different multiple settings. And along the way, we have learned a lot of things to proactively identify the barriers and put a solution to those so that the health systems can realize the clinical and financial benefits within a matter of weeks or months.
Aman and Dr. Berkowitz and Bob, thank you. We are right at time. I appreciate the insights. Most importantly, to the Brooklyn Hospital Center, we appreciate your partnership and the ability to be successful together with you. Thank you both for your time, for joining us, your expertise. For the questions that we have, we'll certainly reach out to you with follow-ups and welcome reach outs and questions where we can connect you to any of the panelists or provide any additional information. But grateful for your time and for spending it with us today. Thank you for joining and have a great afternoon.
Thank you, everyone.
Thank you.
Thank you, everyone. Have a great